Hello, and welcome to today's webinar, Integrating Adolescent Expert Education into Health Professional Training, Findings from a National Effort to Prepare the Next Workforce. I'm Tracy McPherson, and I'm going to be your webinar moderator today, and I'm a Senior Research Scientist in the Public Health Department at NORC at the University of Chicago. I provided my contact information, including my email address, because you're welcome to contact me about anything that we talk about today in this webinar, or you're interested in more information on adolescent screening and brief intervention, or curious about how to get involved with our National Workforce Development Initiative. Today's webinar and all of the webinars in our series are produced in partnership with the NORC at the University of Chicago, the Adolescent Expert Project, the Brief Intervention Group, or the BIG Initiative, and this work is sponsored by the Conrad N Hilton Foundation. And I would encourage you, if you'd like to learn more about our partnership and the work that we're doing, that you visit our expert.webs.com website, and you're welcome to contact the Expert team at NORC at expertteam@norc.org. Today's webinar is one in a series for the 2018-2019 period. As you can see, we have a lot of really interesting and sought-after topics. This particular series is focused on a couple of different things I'd like to draw your attention to. One is a nice review of substance use screening tools, some of the current tools, some that you may not have heard of or be aware about new revisions and updates to those tools. So I would encourage you to take advantage of that webinar and all of the on-demand resources related to our screening tools on our website. In addition, you'll also notice that in talking about adolescent screening and brief intervention and the SBIRT model, we've integrated looking at some of the other risk factors, including how to integrate suicide prevention into the SBIRT model, as well as looking at contemporary trends in prevention and treatment, so exploring some of what the literature is currently saying about risk and protective factors and how that relates to this screening and brief intervention model and how it all comes together to bring substance use and other risk factors together. In addition to that, you'll notice that we have expanded our series to touch on a very important topic around the use of opioid medications, particularly non-medical use of prescription medications among adolescents and young adults. And so I would encourage you to take advantage of that webinar and it's on demand. A lot of very interesting and very useful information, both for educating students and other educators as well as practitioners. And last but not least, you'll see in this series, similar to today, but a little bit different we have a couple of webinars talking about preparing the workforce and their readiness to integrate adolescent screening and brief intervention, both from looking at behavioral health professionals as well as medical professionals. So I welcome all of you to visit our expert.webs.com website /webinars, or you can click on that menu item on our website and download the flyer, sign up, register, and share all of the information about the webinars and their on-demand learning with your colleagues. Today's webinar has a dedicated page where you're going to find all of the information and resources related to today's webinar, including the PowerPoint slides, which are already there, any kind of materials or resources that may be mentioned that we really want to make sure you have easy access to, they will go posted there as well. And you're going to have on-demand access to the recording, which we would encourage you to share with your colleagues. You can use it as a training exercise, a faculty preparation exercise, and you may even want to share this with students. And as well, we're going to be emailing you after the webinar where you'll be able to request a certificate of attendance, and we're going to ask you to complete a very brief evaluation survey, a couple of minutes. This is not like your ordinary satisfaction survey. This is really about getting your input around our webinar series, helping us to think about where your needs are, where we might grow our webinar series. So the evaluation survey is something we look at very, very closely. So I would encourage you, if you can, take a couple of minutes, complete the survey, and then get your certificate of attendance. During today's webinar, you're going to have the opportunity to ask questions. And we have such a wonderful and very full webinar today, which has lots and lots of great information. So I suspect you're going to have questions. But what we're going to do is have you go ahead and put those questions into the questions pane, which is really up, typically up in your control panel of the GoToWebinar software. I often see it in the upper right. You can go ahead, get your questions in. Now, after the webinar, we will compile all those questions. We'll go back to our presenters, get some answers, and then we're going to pull that together in a document that will be posted on that exact same webinar page dedicated specifically for this session today. So that's where you should look. And now we get to really turn to the most exciting part of our webinar today. We have three terrific presenters. These are colleagues that we have known for some time and have really been following their work at the various nursing and social work programs, and have a real opportunity to engage with, really talk about their implementation, learn about the findings from their own evaluation, some of the literature and the presentations that have come out that really could be helpful to you. We have a lot lined up. So what I'm going to do is get started by introducing our first presenter, which is Dr. Stephen Strobbe. And Dr. Strobbe is a clinical associate professor at the University of Michigan School of Nursing and the Department of Psychiatry. He is board certified both in psychiatric and addictions nursing. His professional background has included clinical care, research, administration, and education. He was the first clinical director for the University of Michigan Addictions Treatment Services from 2006 to 2010. Dr. Strobbe has authored nearly 40 peer-reviewed articles, position statements and book chapters, and other resources related to substance use and addictions nursing. He's been an invited speaker both nationally and internationally, including Europe, South America, Southeast Asia, and Iceland. And Dr. Strobbe is a former Fulbright Scholar to Brazil, and he is the immediate past president of the International Nurses Society on Addictions and a fellow of the International Academy of Addictions Nursing and American Academy of Nursing. So it's my pleasure, Dr. Strobbe, to turn this over to you so we can hear a lot of the great things going on at the University of Michigan.
Thanks very much, Dr. McPherson. Welcome, everyone. We're really happy that you're joining us this afternoon. Okay. Looking to advance the slide here. There we go. Thank you. It's my happy task to be able to tell you a little bit of some of the experiences that we've had in efforts to integrate Adolescent SBIRT into the curricula here at the University of Michigan School of Nursing. Our foray into this area was brought about in large part through a national learning collaborative that was supported by the Conrad N Hilton Foundation. And the goal of that initiative was to integrate Adolescent SBIRT into the curricula, specifically at schools of nursing and schools of social work across the country. That project was administered and organized by NORC at the University of Chicago, and Dr. Tracy McPherson, whom you just met, was the principal investigator for that project. Other important partners in that effort were the Cognito company, and you'll be hearing about their interactive computer simulation which was an important part of this project. Because people might have different levels of familiarity and experience in relation to SBIRT, we thought it might be helpful to spend a couple minutes just making certain that everybody was on the same page in relation to this clinical intervention. SAMHSA, the Substance Abuse and Mental Health Services Administration of our federal government, has invested a lot of time, energy, and money into the development, education, and dissemination efforts related to these efforts. By their own definition, SBIRT is a comprehensive, integrated public health approach to the delivery of early intervention and treatment services for people with substance use disorders, as well as those who are at risk of developing these disorders, importantly, before more serious consequences occur. Traditionally, a lot of addictions treatment has occurred in the tertiary care, and when people have become really ill and have suffered serious negative consequences associated with their substance use. Why is this important specifically in the treatment of adolescents and youth? Well, for nearly 20 years now, as part of an excellent monograph that was supported by the Robert Wood Johnson Foundation, problematic use of alcohol, tobacco, and other illicit substances, and the terminology that we used back then was substance abuse. We tend now to speak more in terms of substance use and substance use disorders. That was identified as our nation's #1 health problem. And oftentimes people wouldn't realize that because it's not given the priority in terms of our national healthcare landscape as the problem would suggest that it deserves. In 2009, and keep in mind these were data that came from a few years early in 2005, CASA reported that the annual costs of substance use at local, state, and federal levels in the United States was nearly $500 billion, or $500 billion per year. In 2011, adolescent substance use was identified as our nation's #1 public health problem. That very same year, the Office of the President of the United States reported that the non-medical use of prescription medications was our nation's fastest growing drug problem. And I probably don't need to tell anyone who's listening today the magnitude of the current opioid epidemic. And the adolescent population is by no means exempt from this, and there have been increased rates of across substances. In 2015, this was the first year that drug overdoses became, and these still remain the leading cause of accidental deaths across the United States, now greatly surpassing even traffic fatalities. What are some of the risk factors and consequences that are specific to teens and young adults? These are selected risk factors. One is family history. Heritability or genetics are thought to account for about half of the variants associated with the risk for these disorders. The use of any one substance increases the likelihood that an individual will use another substance, whether it's alcohol or other drugs. Important from a developmental perspective is the fact that the earlier onset of use is a strong predictor for problems later on and throughout adulthood, which speaks to the importance of an earlier identification and intervention with the youth population. Presence of mental health disorders are risk factors for substance use, and conversely, substance use is an increased risk factor then for the development of mental health disorders beyond those symptoms that are caused by the substance itself. And of course, among teens, the influence of peers is very strong. The consequences are legion associated with substance use among youth. These include problems at home, school, interpersonal relationships, legal problems, unwanted sexual encounters, which can result in sexually transmitted diseases, unwanted pregnancies, and then, of course, on the medical side, accidents, injuries, and death. I'd like to give you a brief description of the Hilton Foundation Adolescent Expert project. There were three main components to that. The first was the computer simulation itself. This is a highly interactive online computer simulation that students or whoever it is who's using it can access at any time. They can stop, return to it. It includes a virtual coach named Amanda who helps walk people through 3 clinical scenarios, giving guidance and coaching during the first 2 cases, and then in the third, the practitioner is tending to this more independently. It provides feedback in real time, measuring the level of engagement that the individual has with the virtual adolescent. At the close of the third case scenario, an assessment challenge score is automatically generated, and that measures how effective the choices were on the part of the practitioner in terms of engagement, next suggestions or that are given. Pre and post surveys are given to the individual to see how they felt about their knowledge and their skills regarding SBIRT, both before and after the training, and it also invited qualitative comments. NORC provided an amazing PowerPoint slide deck for this. There are more than 300 slides that teams were allowed to use in whatever way they found fit, and it started from some of the very earliest parts of brief intervention, and for those who want to go on and develop their skills further, takes them through more advanced aspects of motivational interviewing, which is the foundation of brief interventions. We use those in face-to-face clinical simulation in smaller groups with our students, and we'll describe that a little more fully as we go on. There's also a learner's guide to Adolescent SBIRT, and that was made available to us both in electronic and hard copy. And as I just mentioned, here at UMSN, the University of Michigan School of Nursing, we also added face-to-face clinical simulation in clinical groups, generally about 8 students at a time for undergrads, more variable among the master's students. This aspect was not part of the outcomes or evaluation process, which I'll describe as we move on. This was a really fun project to be able to participate in. It took place from January 1st of 2016 through September of 2017. During that time, here at UMSN, we made this program available to more than 600 undergraduate and graduate nursing students. The graduate nursing students took it as a 500 level entry-level master's course in conjunction with their nurse practitioner program and a course for advanced health assessment for advanced practice nursing. As faculty of record, I was able to integrate this program directly into our undergraduate studies as well, so that virtually every undergrad nursing student during their junior year had access to and participated in Adolescent SBIRT. And that included both our traditional baccalaureate or BSN program, as well as a second career track. The training was made available to the clinical faculty, especially those who were part of the psychiatric mental health nursing team. There was positive engagement by all, and we were really pleased with outcomes, feedback from students and faculty. Among the nurse practitioner students, this was made as a voluntary aspect of their studies, for which they received 1% extra course credit and also earned 2 free nursing continuing education credits. More than 90% of the students in that class completed the education training and the pre and post surveys. Interestingly, and keep in mind, these are nurses who are already in practice. Nearly 3/4 of those stated that they had never received any prior training in SBIRT, despite its utility and evidence-based. 85% achieved an assessment challenge score of greater than 75, which was the recommended success level. Positive changes were measured across virtually all of the self-perceived competence and confidence measures. So competence were asking adolescents about their alcohol use, providing feedback to them, tailoring brief interventions, helping them to identify ways by which they might be able to cut down or stop their use. Confidence was their perceived ability to be able to screen adolescents, provide brief motivational counseling, and to refer them, if needed, to added services. The statistical significance was at a p-level of less than 0.001, and that was consistent across virtually all the measures. Students also responded very positively to open-ended questions, seeking their input regarding their experiences. And here's one representative quote. I really enjoyed being able to learn the material in 3 different environments. And he or she was speaking about the different case scenarios. Each step reinforced the previous and seemed to really maximize memory and content retention. I'll remember the SBIRT course for a long time. From that work, we generated a poster that has been exhibited locally, nationally, and internationally, including at the ICN, the International Council of Nurses Congress in Rotterdam in the Netherlands in just last year. This also resulted in a peer-reviewed journal article published in the Journal of Nursing Education titled Preparing Advanced Practice Registered Nursing Students to Deliver Adolescent SBIRT. And the conclusion from that article was that APRN students, or Advanced Practice Registered Nurse students, demonstrated learning and reported marked increases in competency and confidence in the delivery of adolescent SBIRT. This reveals promising results for SBIRT to be integrated into APRN student coursework. And of course, we invite you to access and read this. One of the most important aspects of this seminar is I hope that we all hope that the listeners will see that these are attainable initiatives and that they were well received by students and faculty. After the Conrad Hilton project, we decided to retain our access to the Cognito computer simulation and have continued to make that available to our undergraduate students. It's been integrated into their junior year, and it, as you're already familiar now, includes the interactive computer simulation, and this was complemented by face-to-face simulation in their clinical groups of 8 students each. These data focus exclusively on the computer simulation during the 2018 calendar year with 144 students. Of those, 93% were successful on their first attempt. Their pre and post survey items aligned very closely with those results that you just saw for the graduate students. To that, though, Cognito added, in addition to self-perceived competence and confidence, they also added a factor for readiness to deliver adolescent SBIRT, and qualitative responses were also sought. Here are graphics, and you can take a closer look at these when you have as you have access to the slides. But again, looking at the areas of self-perceived competence, confidence, readiness, again, p-values at statistical significance of less than 0.001 in all cases, and you can see the changes in their overall scores across those 3 domains of competence, confidence, and readiness. We also have some examples of the qualitative responses that we received from the undergraduate nursing students. They praised the themes that emerged and were seen frequently were the fact that they found this experience to be realistic, structured, and interactive. And as a faculty member, I can tell you it was really gratifying to hear students say, nursing, a lot is asked of nursing students. And these days there's a marked increase in the emphasis on clinical simulation. They spend a lot of time in class, in the hospitals, and doing additional work outside of the classroom and their clinical setting. And so for them to come and spontaneously share, Dr. Strobe, that was the best simulation we've ever done, is really reinforcing to hear. Their comments were, the simulation was very similar to situations I may encounter in real practice. The outline was very well organized. so I had a direction on how to intervene when adolescents could be most motivated. Another stated, I liked how the conversation, especially on the adolescents end, was very realistic and similar to things I would have said when I was that age. I also liked how easy to use it was and how the generated responses always seemed to convey the emotions and things I wanted to be said by the practitioner. This resulted in another poster. I'm really proud of the fact that the person who you see on the left of your screen is an honors student with whom I had the opportunity to work, and this ended up being she was first author for this poster. Beyond that, she's also serving as the first author, senior author on a paper which is currently in review and holds great promise in that this would be for a special issue in a journal of pediatric nursing that focuses specifically on substance use among children and adolescents. And the team's conclusion related to this project was that Adolescent Expert training was successfully integrated into the undergraduate nursing curriculum at the University of Michigan. This study provides support for the future implementation of virtual simulation-based learning in undergraduate nursing curricula. So the fact that this was a project that nursing students and honor students wanted to be involved was also really validating. Finally, we have a project ongoing to integrate Adolescent Expert project into a clinical setting. We're very close partners with the University of Michigan Health System and Michigan Medicine. And in our work in mental health and wellness, we have strong partnerships with both an adolescent or child and adolescent as well as adult inpatient unit. Our current project, which is foundation funded, is to provide interprofessional training to nurses, physicians, social workers, psychologists, and activities therapists, and to integrate Adolescent Expert into the care delivery model on an inpatient child and adolescent mental health and wellness unit at C.S. Mott Children's Hospital at the University of Michigan. These are kids who are at even higher risk for substance use. As we mentioned, mental health concerns increase risk for substance use, which can contribute to worse outcomes. So if we're able to identify this risk sooner among a high-risk population and either help keep kids away from substance use or intervene early, the clinical outcomes are likely to be markedly improved. I want to thank you for your time and attention, for the support of NORC in offering this to you and to us. I would like to encourage you to give Adolescent Expert a try, and I hope you have as much fun with it as we have. Thanks very much, and enjoy the rest of the afternoon with the next seminar speakers.
Thank you, Dr. Strobe. It's so nice to look at how the project unfolded and how you've continued to integrate it at different levels of education and how you've integrated different types of experience in learning. And it's really nice to see the evaluation findings that you discovered. And what's really interesting about it is in some of the other evaluations that we are doing with other schools, we appear to be replicating some of the findings. So I think that's particularly interesting, and I'm hoping as we build more literature around this and demonstrating what pieces are effective and what tools are out there to help improve all of our toolboxes as educators or professionals, we'll be building and adding to the literature to help inform other programs and really thinking about what they can realistically and feasibly do, since you've demonstrated that it is feasible. So that's very exciting, and it was a pleasure to hear about your program. Okay, so again, it's my pleasure to introduce our next presenter. Dr. Shauna Aquavita is an associate professor at the School of Social Work in the College of Allied Health Sciences at the University of Cincinnati. She has a decade of social work experience working with individuals who have been diagnosed with mental health and substance use disorders. She completed a pre-doctorate fellowship in maternal and child health at the University of Maryland, Baltimore, and a postdoctorate at Johns Hopkins University in the Behavioral Pharmacology Research Unit. Her research focuses on substance use disorders, including tobacco use among vulnerable populations, specifically pregnant women, and she is also a proponent of interprofessional education and collaboration. So it's my pleasure to turn it over to you, Dr. Acquavita, so we can hear more about what's happening in your social work program.
Thank you so much, Dr. McPherson. So what I would like to start first with is a polling question. So if people could please answer the following question. My institution currently offers an interprofessional course on SBIRT. If you could please select one, that would be yes, no, or you're unsure. So we'll just take a few seconds for you all to answer the poll. Okay, so we've got some poll results. So about 18% of you do offer an interprofessional course on SBIRT. All right, and about 55% don't, and 28% are unsure. Okay, well, thank you for that. That gives me a sense of the audience. So what I would like to do is just discuss with you how our interprofessional course took place and how we integrated information on adolescents. So in 2015, the University of Cincinnati received an SBIRT grant from SAMHSA. And so the College of Medicine, Nursing, Pharmacy, and Social Work all worked together on this interprofessional training program. So our goal was to train nursing, medicine, pharmacy, and social work students, preceptors, field instructors, and health professionals over this 3-year period. We also created, tested, and disseminated 2 SBIRT curriculum models on special populations, and we did create an online SBIRT CEU course for our medical center. So those did not focus on adolescents. So we had to look outside of our institution for resources on adolescents. So I will talk a little bit more about that. So just to give you some background, the University of Cincinnati's Academic Health Center houses these colleges together. So we have the College of Medicine, the College of Nursing, the College of Pharmacy, and the College of Allied Health Sciences. And the School of Social Work is housed in the College of Allied Health Sciences. So all of these professions came together to take an interprofessional course in SBIRT. And there were definitely some challenges. People had different course schedules, so sometimes midterms occurred when we needed to meet in person for our midterms, so we really had to work on coordinating schedules, and also different colleges had used different systems online to teach, and so we had to figure out how we could all get together and use the same online course system. So there were a lot of challenges that we overcame, and so those of you who don't have an interprofessional course, I can understand why, because it was definitely a challenge that we had to overcome. But luckily, I had a great group of individuals who helped really brainstorm and work through this. So we actually designed a semester-long course, and there was a 3-part training, student training course. So the course was 2 to 3 credits, and it was a blended course. And so the first 6 weeks was online education. And so I'm going to talk a little bit about what some of the things that we had students do online in the next slide. But we also had a standardized patient experience. If you're not familiar with that, that is an actor that portrays a certain case. And that was our midterm. And then we had clinical experiences that students had to sign up for, and that was at men's and women's homeless shelters and also at our hospital. So we engaged in that. So the online course components, we used PowerPoints, videos, journal articles, and simulations. We used Cognito for online content. We also used modules from other online trainings. In Ohio, where the University of Cincinnati is located, they have a free e-based academy that actually has 2 modules on SBIRT, so we had students take that. They also have a course, one of the modules includes how to implement motivational interviewing, so students were able to get familiarity with that. We also recommended other modules to students that were available online. So there were some on pregnancy and SBIRT. There was also a national one on LGBTQ module. And then we used one from IRETA that I'll talk a little bit more about on youth. So those were kind of the online course components that we did. One thing I do want to mention is that in order for students to understand what their midterm exam was going to be in person with the standardized patient is I had students view an SBIRT video and then grade the video using our proficiency checklist that we were going to use. We used the Peru, and that's a SBIRT short-term proficiency checklist, the clinical version. And so it really helped the students understand what they were being graded on. If you want to know what the authors are of that study, so it's Pringle, Kowalczyk, Myers, and Seal, and it's from 2012, and it's the National SBIRT Residency Training Project in the Journal of Graduate Medical Education. So our interprofessional in-person components, before we had the standardized patient experience, we had optional office hours for students, where students came and practiced SBIRT with an instructor and fellow peers. We reviewed the grading criteria. We talked about the structure of the exam and how to prepare. We also had students practice. So for example, we'd have students do sit and we'd do round robin style where the instructor would act out a client and then students would administer the screenings and then conduct a brief intervention. So our specific standardized patient experience, it's a 15-minute exam where 2 students from different disciplines work together to administer the audit and the DAST. Ours was an adult case, but in this case, it had the individual screen positive for 2 substances with different motivations on each substance, so they had to deal with resistance. I told the students that we try and give them the worst case scenario in one way, as it's timed, and so you have limited time to get things done, and then you also have someone who doesn't want to change use on one substance, and so how do you handle that one? And we learned this because we had a previous grant that focused on smoking cessation, and students had to do some smoking cessation counseling, and students didn't know how to deal with resistance with that. So moving forward, it really helped them process things on how to handle when things don't go as they planned. So, and then we had the clinical experiences, and the clinical experiences were staffed by either a faculty or staff member. So students see the clients and then they debrief with faculty or staff. So each experience is 2 to 3 hours. And they would also get a tour of the facility. So that was really helpful for them to get to know different resources in the area. Okay, so I have another polling question, and it says, my college department offers education and/or training on SBIRT with adolescents for students. So if you could please select one, yes, no, or unsure. And I'll give you a little bit of time to answer that. Okay, so our results are that about 13% of you offer education and training on SBIRT with Adolescents for students, about 48% don't, and some of you are unsure. Well, I'm going to be talking about how you could conceptualize implementing this with some modules and different things, resources that you could use that may make your life a little easier so you don't have to create it yourself. So in our course, we created a specific module in Adolescents, and that was required for the students who took the course for 3 credits. Although we did have some students who took the module even if it wasn't required because they had an interest in working with adolescents. So initially, we actually had students complete the IRETA Online Adolescent Expert module, and IRETA stands for the Institute for Research, Education, and Training in Addictions, and this is a public health nonprofit organization. They have a lot of online courses that people can take for free, and so it's a great resource. So they have this Online Adolescent Expert module. That is accessible to anyone, and it takes approximately 2 to 3 hours to complete. And so one of the feedback we got from the students were, I work with high schoolers, and therefore I found the module on adolescent substance abuse to be the most relevant to my work responsibilities. After that, then students took the SBI with Adolescents, the Cognito online simulation that was previously discussed. And as mentioned, that's an interactive role play simulation. And so really they're building on their SBIRT skills and conducting a screening and brief intervention with adolescent patients. So one of the feedback that we received from students who took this was, I found these tools to be most useful because the Cognito trainings allowed me to practice with the clients in the age range I currently work with, which are youth. So we did have some students who didn't use the SBIRT module, but I am going to be talking about those who did use the Adolescent SBIRT module. So we had about 198 students consented to the overall study, and then 78 of those students completed the Adolescent module. So just to give you some information, majority of those students were female. They were social workers, and then medicine, and then pharmacy and nursing were less likely to have completed that module. About 47% of students had not taken prior substance use disorders training. About 46% had prior motivational interviewing skills, and about 37% had prior motivational interviewing skills practice. So Cognito actually provides a pre-test, post-test option in their simulation. So Cognito had specifically asked these questions before the students completed the online simulation and then after. And so I just want to remind people that students had already taken the online adolescent module in SBIRT by IRETA. And so we conducted paired t-test. And so while we had 78 students complete the module, these questions were optional. And so we only had 37 students complete both pre and post-test that could be matched. So the questions were, please indicate how professionally competent you feel in performing these alcohol and drug-related aspects when working with an adolescent. And they would mark not at all competent, only a little, moderately, and very. And so they answered screening adolescents for alcohol and drug problems using a formal standardized screening instrument, discussing and advising adolescents to reduce or halt their drinking and drug use behavior, providing personalized feedback to adolescents about their risk associated with drinking and drug use, tailoring brief interventions to adolescents' motivational level, helping adolescents identify benefits of cutting back or stopping use of alcohol and drugs, helping adolescents identify challenges and barriers in cutting back or stopping use of alcohol or drugs, and then helping adolescents develop a personal plan for cutting back or stopping alcohol and drug use. Finally, engaging parents in the discussion about treatment. So all had significant results indicating positive change, although helping adolescents identify benefits of cutting back or stopping use of alcohol and drugs had less of a significant effect than the others, as well as engaging parents in the discussion about treatment. Also, engaging parents in the discussion about treatment had a medium effect size versus the large effect size seen by others. So also after completion of the module, we had a couple other questions for students to answer. And one was, I feel confident in my ability to screen adolescents for substance use. And so we had 55 students answer that one. And so about 25% strongly agreed with that. And then 71% agreed. And so we only had 4% who disagreed. And then the next question was, how likely are you to conduct substance use screening, brief interventions, and referral to adolescents? And we had 52 students who responded to that. And we had, again, 25% very likely, and then 50% likely, and then 21% unlikely, and then 4% very unlikely. So about 75% of students are likely to use SBIRT with adolescents, and approximately 96% of students agreed that they feel confident in their ability to screen adolescents for substance use. So I think that really speaks to being able to use online resources for this. So we did do a 30-day follow-up after course completion. And so these were some of the quotes that we got from students. It says, I work with teens and some of them have experienced substance abuse issues. It is helpful to use this class as a resource when working with these adolescents. The use and practice of motivational interviewing has helped me in adolescent interventions. I just graduated with my social work degree, and no matter what area I end up going into, I will encounter substance abuse issues. So the section about SBIRT with adolescents applied to what I hope to do. We also conducted a 12-month follow-up, and these are some comments about barriers to implementing SBIRT. One student said, motivation and willingness to change in teenagers, that was a barrier to implementing SBIRT. We also had said clients are too young, so they could have been working with very young children, and so they may not have been able to implement SBIRT. Another quote was, I'm working with children in foster care now, and sometimes I find it hard to use some aspects of SBIRT with this population, especially with questions like, has your family ever commented on your drug or alcohol use? Because these children are not living at home. It just sometimes doesn't transfer. So from all of these barriers, I think there's different ways that we could address them. So motivation and willingness to change in teenagers. If you're really looking to train students on how to do this, I would suggest doing in-person role plays with them or doing a standardized patient experience with a teenager. Some of the standardized patients previous experiences I've used for students, we've used homeschool students who have to have specific credits and different things, and we'd have those students come in and act as teenagers and follow through and do a specific scenario. So that is something that you could consider. Clients are too young. Of course, that can definitely be the case. However, it'd be important to talk to students or educate students that maybe we consider how we could implement this with the parents of the clients. How is that impacting them? Is there anything going on with the parents of these clients that we can educate them? And then working with children in foster care. So even addressing it with foster care youth, integrating their primary care doctors with their care. So I know at University of Cincinnati, we have a relationship with Children's Hospital of Cincinnati, and they have a specific department made for foster care children where foster care children can get medical care. And so integrating SBIRT into that type of practice can be helpful. So just in summary, utilizing outside resources can create effective online modules if resources are properly vetted. So we had a number of resources that we first tried out ourselves in order to make sure that they made sense. And so as I mentioned, we had a module on LGBTQ that we had students use. And so we made sure to try that out to make sure that we knew how long it took. And you can get a certificate of completion afterwards. And so we would have the students upload this certificate to make sure that they had completed the module. So that's how we knew. Now, some of the modules would send it to their home, and so then students wouldn't be able to upload it right away, but we would just say, just take a screenshot of the last slide or what have you, and we would then give them credit for that. So there are ways around that. The other thing is to consider developing further materials in the module on how to talk to adolescents and about cutting back or stopping, and how to talk to parents about their child's substance use. So as I mentioned in the survey that we did to the students with the t-tests, it seems that students out of all of them felt the most uncomfortable or just didn't know how to talk about adolescence, about cutting back or stopping. And that could be because we want to encourage them to stop, but we don't want to be preachy. And so how do we talk to them about cutting back and getting adolescents to listen to us? So that is something that we could think about developing further materials in the module about that. And then also how to talk to parents about their child's substance use. I think that is the huge thing in how do we engage with the parents, and also how do you tell the child, we are going to be talking to your parents about their substance abuse. So, so having that discussion and knowing how to approach it is important. The other thing is we need future resources on how to implement SBIRT with adolescents with special needs and situations, such as those in unstable living environments and those with parents who have a substance use disorder. So how do you address SBIRT in children who are homeless or who are in foster care? So those are some questions on what type of tools we can use for that. And how about we have students who might screen children, and the children screen negative, but then they talk about their concerns because their parents have a substance use disorder and they're afraid to get in the car because their parent is intoxicated or their parents are using at home. So figuring out how to talk with those students in order to be able to have them address this at their institution or agency that they work with is important to consider. So I would like to acknowledge some individuals who really helped me move forward in this endeavor. We still have this course, and so it's been a great experience, and students really speak of it highly. We've won some university awards for it, I'm happy to say, and it's really been a cooperative effort. I want to acknowledge Rachel Smith, our program manager and data analysis person, because she really put together all these statistics. Our co-investigators, so we have Dr. Ruth Ann Van Loon from the School of Social Work, Dr. Bonnie Brem from the College of Nursing, Tiffany Deers from the College of Medicine, and Carissa Kim from the College of Pharmacy. All of these individuals really worked hard to create a course for their students and had to overcome a lot of barriers in order for us to implement this integrated course that was interprofessionally driven. So we have just recently published on this course, and so if you're interested in learning more about how we did that and what the specific curriculum and field model is, you can access this. and it's called the SBIRT Interprofessional Curriculum and Field Model. It's in the Journal of Social Work Practice in the Addictions, and as I said, it's just released. It's the most recent issue, and so we had the opportunity to have this accepted. And obviously, if you have any questions for me, feel free to reach out to me. So I'm going to pass this over to Dr. McPherson. So if you, I really appreciate your time, and again, reach out to me if you have any questions.
Thank you, Dr. Aquilita. This has been terrific, hearing about the social work program at University of Cincinnati. And one of the things that has struck me across the two sessions so far is the use of some similar measures. And I think, one of the things that we've learned early on in evaluating adolescent expert education is many of the tools, existing tools out there, and we use them in pre-post surveys, were designed for medical residency programs and other disciplines. And it's really nice to see we've taken some of those similar measures, like from Peru and other places, and we're using them across different programs. And I think that will help the field, because some of these measures also have been adapted from working with adults to adolescents. So there's some change there, and it gives us an opportunity to really look at our measures, think about the psychometrics of those measures, and seeing how they perform with different levels of education, different disciplines. So that was one observation that I see, and thinking about the measures we use, I think there's some really good opportunity to inform the field around measurement. So that was terrific. The other observation that I thought was striking, and it's exciting to see that we have colleagues with us that joined our session who not only may be doing some implementation, maybe it's the screening piece, maybe it's the motivational interviewing piece, maybe it's the brief intervention piece. Some have maybe fully implemented education around those components in their programs. But what was also nice is to see that we still have a lot of opportunity. There are colleagues with us who haven't yet integrated it, or maybe they're thinking about it, and that's why they've joined us today to hear more about how they can do it. It's feasible. And so we have a real opportunity to support them and help build their own efficacy around, or their self-efficacy around implementing in their program. And I'll be pointing to some resources later on that I think will be helpful to our colleagues who are really thinking about implementing. The other thing that struck me, and I'm so glad that you mentioned your publication, and same with Dr. Strobe. It's really nice to see where the findings are getting published, where they're being presented, just to know where to look and help disseminate information about where you're disseminating. And that special issue that you mentioned, I hope what we'll do is find a link. Maybe we'll get one from you for that special issue that you mentioned. And I think that's a nice way to point our colleagues to a lot of different things that are going on that they may not know about. Different types of programs, different types of evaluations. So I definitely want to get that from you and get that posted. We may even include that in the Q&A document. So thank you very much. Really enjoyed that. And I think we will, let's see, we're going to go ahead and we're going to introduce our next speaker. Thank you. So today with us, we have another excellent speaker today to join us, Dr. Kathy Ketting. And Dr. Ketting is a tenured associate professor of nursing at St. Louis University School of Nursing, where she has been primarily responsible for integrating screening, brief intervention, and referral to treatment in undergraduate and pre-licensure graduate nursing curriculums. Dr. Ketting is a board-certified pediatric and family nurse practitioner who has specialty certification in pediatric and adolescent mental health, and her practice of over past 13 years has included mainly vulnerable populations. Her area of research is forensic nursing, where she focuses on health outcomes in people with intellectual disabilities as a result of adverse childhood events and violence. She is also a member of the Sexual Assault Advisory Board at St. Louis University, where she has been involved in Title IX policies and their application to various university cases. So join me in welcoming Dr. Ketting. Dr. Ketting, I'm going to turn it over to you now.
Thank you, Dr. McPherson. And I also want to thank the entire SBIRT at NORC group for inviting me to be a part of today's panel. As some of you may know, I was a part of the original SBIRT Collaborative Track B group that was described by Stephen earlier. And so we also began our implementation of screening brief intervention for adolescents by Cognito in spring of 2016. And since that semester, we've been using this online simulation as a part of our traditional baccalaureate curriculum at St. Louis University. St. Louis University is a medium-sized institution. We're one of the 31 Jesuit universities. And the School of Nursing at St. Louis University is one of the largest at the university. We graduate approximately 140 to 175 students per year, and we have been doing that consistently over the last 3 years. As Dr. McPherson stated, my background is as a primary care, pediatric, and family nurse practitioner with a specialty certification in primary and pediatric primary mental health. And at this point in time, I've moved over to the undergraduate traditional baccalaureate program and some of the other pre-licensure programs that we offer at the School of Nursing, where I really focus on teaching clinical in the psychiatric mental health nursing curriculum. And so being a nurse practitioner and working with patients using this type of model in the past in practice and seeing how much substance abuse affects chronic illness, creates chronic illness, and affects health outcomes long term was really my impetus for getting SBIRT simulation into the baccalaureate and pre-licensure program. Okay, so at the School of Nursing at St. Louis University, we have spent most of our time implementing this in the baccalaureate, the traditional baccalaureate program. Our students that we educate are junior level students, so they're juniors credit-wise too, so it's typically the third year. And the bulk of them are 20 to 21 years old. And this is going to be their first exposure to psychiatric mental health patients in the clinical setting. And they are in different clinical settings too. So some were with me and they were in a more traditional inpatient psych acute setting, where some of them were in a forensic setting and some of them did do some work in outpatient settings also. So they do get various clinical experience throughout the semester as they take the course. So using screening brief interventions for adolescents by Cognito simulation, we made it a required clinical experience. So we always made it a part of the clinical section of the course. What I found for these students is that they need a lot of explanation and they need a lot of practice. Mainly due to their age and maturity level, they were somewhat naive to information about risky levels of drinking, and quite naive to actually having a conversation with a patient in this manner. And in a way, they were pretty much the hardest group to convince that we really needed to spend entire clinical time focusing on this type of conversation. And I saw that quite a bit in the qualitative reflection notes that they also gave us. with the initial 3-semester implementation that we did. A lot of them wanted to actually do it at home by themselves, and as an experienced educator, I know that they wouldn't have done that if I had given them that choice. Therefore, they didn't have a choice, and we actually took an entire clinical day and provided this education. Now, the second group that I've spread out to was incorporating the same SBIRT Cognito simulation for the Accelerated Masters of Nursing students. And this is what we would call a generalist master's program. They're older students. Many are in their late 20s, 30s, even 40s. They already have baccalaureate degrees. Some of them have other master's degrees, and they are wanting to enter the nursing field. A huge amount of these students want to go on to become nurse practitioners. And what was really interesting was that the overall reaction to the simulation was a little bit different for this group. They really understood a lot more about the gravity of the problem of risky drinking and its effects on health. And I think they were a little bit more motivated to learn as much as they could. They really enjoyed the simulation and had lots of positive comments, as did the undergraduates. But I just sort of wanted to lay that out there as a word of caution that you may have to motivate the students to want to do this type of education as a little bit more than you may think you have to. A lot of them, as I stated, were very naive to the idea that this was a problem they would be encountering in nursing. So the students basically had different needs, but we still used the same educational model each time we implemented. So initially, we decided to use Bandera's theories of self-efficacy for the simulation as our underlying theoretical framework in our implementation model. And we had goals where we focused specifically on two things. One was increasing their confidence level in their ability to use these skills. And the second goal was to increase their knowledge level regarding risky drinking. So to do this, we started by introducing the material via recorded PowerPoint after they had been given the pretest in class during didactic class one day in clinical. We did get IRB consent, and we made it a part of the course, a required part of the course, and gave them the option to have their data not be used if that's what they wanted to do, and that we wouldn't look at those consents until after all the course grades had been calculated, and we would then see who wanted to have their information used. And as it turned out, all of them did give consent for that. So our first sample was 59 students. So after we introduced the PowerPoint on the Blackboard, they came to the clinical simulation in the School of Nursing computer lab. I found that also I would need to use some PowerPoints to have on hand, and this kind of goes with other simulation models when you're trying to do high fidelity simulation, that you actually give them material to use during the simulation so that they can either use it to refer to or interact with as needed. So when we started the computer simulation by Cognito, they received a copy of the craft and also the scoring for the craft to understand the idea of risk assessment. And then there's also in the PowerPoint deck that's been described by Stephen, a really nice one-page outline of the brief negotiated interview. And I wanted to have them have that as they went through the different conversations. I think, like I said, what we found to be barriers were sometimes were really just our own barriers. The motivation was different based on the type of student we were looking at. And we sort of felt that, again, that they probably needed to be very well prepared before they went into the simulation with the PowerPoint and also with what they had in their hands while they did the simulation. So prior to the first implementation, which was back in spring of 2016, I did have a simulation session for all my clinical faculty so they could try it out. They were also invited to attend the separate clinical sessions held in the computer lab at the School of Nursing on the appropriate clinical day. I found that at first clinical faculty were pretty good about coming, and then they sort of decided that it was a good idea that they could have a day off and that I would take their clinical. As far as evaluation, I used a pre-test, post-test. I added in guided reflection notes that they did after they finished the entire simulation and after they finished the built-in Cognito simulation assessment. And again, I made it a forced clinical day in order to make sure that the undergraduates would actually do the education. I really did find that our goals were met, that we did increase their confidence in their skills, and we did increase their knowledge in risky drinking behaviors. And I'll get to that in a little bit when I discuss the article. So I did use measures from the Learner's Guide or Instructor's Manual in the subsequent semesters since I started the implementation and finished the Track B project, which would have been in September of 2017. So in the last 6 or 7 semesters, I've used measures straight from the Learning Guide so we can take a look at making sure that our goals of increasing confidence and skills and knowledge of risky drinking behavior was maintained, and we have always received positive results regarding knowledge level and confidence. I also opened up the instructor's manual to my clinical faculty and asked them to try some of the role plays that are in there specifically from the B&I section of the learner's manual. And they had very good success in doing this. They actually did this after clinical in a post-conference at the clinical site. And both the instructors and students remarked that they found it very helpful to reinforce the concepts that they had previously learned in the computer simulation, and again, go through the actual steps of the brief negotiated interview that they learned. I also learned a little bit of a lesson in terms of the student reflections. I think that, again, because our undergraduates are, the junior year is the busiest year with these students and they're highly stressed. They want to be able to get things done and get it over with. So I sometimes felt that some of their reflective notes, while most of them were very positive, some of them, I had some saying like, I've never heard an adolescent talk like this, you know, that type of stuff. So after the first time that came through as a bit of a theme, I was able to anticipate that and actually have a discussion with them after the simulation in regards to, you know, what is the reality of working with adolescents, because they are very limited at this point. Whereas with my accelerated master's, didn't have that type of comments. I think because they're older, more mature, and have had more experiences, and they're graduate students, that they actually come to the table better equipped to deal with this type of information. So this is the citation of the publication. It came out in, I believe, of June of 2017. It's in the Archives of Psychiatric Nursing. I do lay out the theoretical framework and also the nursing education simulation framework by Jeffries that we used when we did the initial implementations in the first 3 semesters. Again, I did use the 1 sample pre-test, post-test, and first time around in the first 3 semesters, we used our own measures that we created in order to evaluate confidence level and knowledge level. And the whole tool actually is published in that publication. So it's available to you if you go ahead and look this up. And in the results, I talk about our statistical significance in t-tests and Wilcoxon signed ranks. And one of the goals of my publication was to be sure that I was very transparent in the statistical analysis of the results that I presented. So I actually went through all the requirements of data that's needed to do those statistical techniques. And I did this because I have found that in many studies, particularly discussing nursing education, that there's not a consistent focus on this type of statistical transparency. I think it's okay if your P is not the number that you want. And I think it's good for all of us as researchers to talk about this in our research studies and talk about why this might be the case. So I would also put a plea out for all of us as researchers to think about the types of statistical analysis that we're using also to show these types of concepts. I think that besides myself, my 2 previous colleagues have shown that this is a very positive type of implementation model using an excellent simulation and simulation tool for students. But unless it's done, I think, in a very well thought out and structured manner, you're only going to be looking for the results you want. So we need to look at all the results that we get to see why those things occur. And I guess I did learn some lessons here. The first of all is you can easily put this type of curriculum into your undergraduate and graduate programs in an on-campus format, and I used it exclusively as an on-campus format. Our accelerated master's students are on-campus students because this is their first foray into the study of nursing. So they need to be on the ground with us in order to learn most effectively. You have to think a lot about how you're going to sustain this program. One of the things you must have, I found, is faculty that's committed to use this type of simulation, take the time to plan it out, put it into a clinical day, make sure you get buy-in from your other clinical instructors as to why you're going to, steal a day out of their clinical site. And I also found that funding to purchase licenses was something that was very important also. We have been undergoing a massive budget crisis at St. Louis University for the past 4 years. And at the end of the first implementation, actually had some money left over and wrestled it out of the arms of the university so that we could actually buy some licenses for the next few semesters to continue this implementation. So at my university, getting funding is definitely an issue to think about. I really felt too that getting this out into the agencies, I had some issues with. I spoke about it to nursing educators at various clinical sites and agencies, and while they were open to having their own nurses educated they couldn't seem to actually find a time for us to set up a training program for them at all. So I think a lot of this goes back to the idea of why we're doing what we're doing, which is educating future healthcare providers to be able to practice this in the field, because we still have a lot of people in practice who don't practice this. And so we're not passing it on. In order to get it into practice, we have to continue to educate people who practice this way. I actually even had a colleague of mine who's in the trauma education program over at St. Louis University Hospital present this to their curriculum committee in the trauma group. And while they liked it, they just said, we don't think we have time. So it was kind of interesting, because at the same time, we also had a large lawsuit at the university regarding our providers in the SLU care practice and not properly assessing people for substance abuse. So when I had spoken to some of the administrators there, they were interested in doing it because of that. But again, there were some funding issues. What are the future suggestions that I think we should probably have a discussion about at some point in terms of screening brief intervention for adolescent simulation is its use in non-native speakers. I have a pretty significant amount of students in the baccalaureate, but in the accelerated master's program, quite a bit of non-native speakers. So these are students who have been in the United States and they speak English and they understand it. But I noticed that these students consistently scored lower than my native English speakers. And I think there might be something in here in terms of the context of the conversation. So I just wanted to put a heads up in there that if you have students who, a bit of students that are non-native speakers, just know that they may score lower than your non-native English speakers. There may be various reasons why. I'm not sure if there's some sort of cultural bias or cultural differences that come up in this simulation, but I think it's something that we probably need to address at some point so that you're aware of the fact that it isn't because these students aren't smart and don't understand what they're doing. I just think that when they translate this in context back into their heads, they have problems doing the assessment. And that ends my comments here today. I want to thank you for taking the time today. And I'm going to go ahead and turn it back over to Dr. McPherson again.
Well, thank you, Dr. Ketting. Again, another terrific presentation, very informative. All three of the experiences that everyone has shared have been really, really interesting. And I have a couple of reactions to some of the things that you mentioned that seem to be a common theme. And one is that there's such the importance of practice and more practice, and whether it's standardized patients or it's role plays in class, or you're using a drama department, but it's the practice, live and in simulation, and that makes a difference. And so that's a commonality across the programs, and I think we all can definitely appreciate the value of practice and the importance of it, and not just sort of speaking at our students, but really engaging them in a learning and experiential process. So I appreciate that has emerged today from our session. Another thing that struck me is it was something that you mentioned about the transparency in our data analysis, our data collection, the statistical techniques that we use, and presenting kind of a full array of findings that we have out there. We don't always reach statistical significance, but there are lots of things that we can reflect on and that we need to share with our community of researchers and practitioners, and really being more transparent in that effort. So that definitely struck me. A couple of other things that I really appreciated is mentioning the challenges of the role of nurse educators and training, whether it's the preceptors, those who do supervision, other educators, and there are a lot of barriers to that in both nursing and social work, and engaging the field instructors and the field directors in social work. And we learned very early in our first phase of work that it was so important to bring on board all those key stakeholders, and have really been thoughtful about our phase 2 effort and programs who want to be able to focus beyond students to really also focus on those other groups, and helping to support the implementation and fostering practice uptake in settings in their community and placement sites and so forth. So thank you for mentioning that. The other thing I wanted to share too, which you mentioned, really thinking about our curriculum materials and our approaches for non-native speakers. And I really think that's such an important point, and something that many may not know that we've been working on behind the scenes with our colleagues at Loyola University Chicago School of Social Work, and they have an interprofessional program with nursing and medicine. And we are working with them to not only translate the curriculum that our three presenters have been talking about, not only translate it into Spanish. Of course, there are variations, cultural variations as well, that we can appreciate about the use of an adapted or linguistically adapted curriculum in Chicago versus what it might be in another geographical region. You can't just adapt it in Spanish and it just work for all groups and all places. But one of the things that we're trying to do is really listen to that need, see where we can begin to make some of those adaptations. It won't be a one-size-fits-all, but we are certainly working on that. And so we're looking forward to releasing that and getting people to use it and think about it and give us feedback on it. So I really appreciate you bringing that point up as well. So I think what we will do from here is a couple of things I want to do as we close our session today is, in our last few minutes, I first want to thank our terrific speakers and the fantastic materials and information and experience they've shared with us today. I'm really looking forward to sharing this with our colleagues who are really trying to see that it is feasible. What do those models look like? How do you evaluate it? What are you evaluating? I think this kind of information can be helpful for those both early in their process of changing their courses and curriculums, as well as those who have already been doing so. So thank you all for that. And I want to remind everyone that the PowerPoint slides are on this dedicated web page on our sbirt.webs.com website. And you're going to be getting access to that on demand. And we will also be sending you a follow-up email that will have information about how to request your certificate of attendance and the evaluation survey, which, again, I can't stress enough, is really important to helping us monitor our own performance and develop and offer things that are of value to you who come to listen to all of these wonderful on-demand learnings and the webinars. With that, I also want to mention, as we wrap up, there are some resources that could be helpful to those who are on today. One, you have my contact information, my email address here, and if you have questions about what you learned today, about evaluating your programs, about the survey measures, about implementation, about training, technical assistance around if I had to focus on training, what would and I have 2 hours to do it, you want guidance on what are the pieces that we would recommend you focusing on. That's what we're here to do, is to be able to help provide some technical assistance by phone. So don't be shy about reaching out. The other thing I want to mention If you'd like to learn more about this national initiative to prepare the workforce of social work and nursing professionals, as well as interprofessional programs, let me make sure I add that, we have a learning collaborative that you can engage with at whatever level or frequency that you want. It's open. It's a sharing and learning experience, and to connect with other peers and hear about what they're doing, offer some lessons learned, or ask the group questions about some of the challenges that you're facing that you'd like to overcome. And so you can sign up for our learning collaborative, and you would get a communication a couple of times a month, and that's really all. We like to be very focused and limited. And then we have a learning collaborative call once a month. All of those dates are posted on our website under the Learning Collaborative tab. And also, you have access to the curriculum that many of our speakers have been presenting on. And if you go to our website and you click on the curriculum tab, you can request a copy, electronic copy of those materials. And also, if you're interested in learning about ways to implement and evaluate in your own program, and you're looking for additional support, access to the pre-post surveys, the curriculum, a whole package of things that we can offer you, including access to the SBI with Adolescent Simulation, I would encourage you to go to our Learning Collaborative page and look for what we call our Track C program, and this is an implementation and evaluation track that is opening up and will give access to a lot of things I think could be very useful to everyone. So I have also posted onto our webinar page what I call a sneak peek of these resources. It's already available. Download it, and you can learn more about these 3 different components. And with that, we are going to thank all of you for attending, and all of our speakers and all of our partners, and I hope everyone has a great rest of the afternoon. Thank you for joining us.